one of the few things that many people do in intensive care is to do an ammonia level. Okay. Now, ammonia levels are, so if somebody asks you which patients will do an ammonia level, so what do you think the reason could be to do an ammonia level? Sachin, what do you think we should do an ammonia level for? Why do you do an ammonia level? Why to do an ammonia level? Tell me the specific situations why you will do an ammonia level.
Patient is lethargy.
Lethargy. All right. So you mean to say if the patient is drowsy, you like correct? You like to do an ammonia level. You're right on that. Because why do you want to do that?
Rule out ammonia.
So whether to rule out, whether to rule in, whether this patient is an undiagnosed case of probable liver failure. All right. Or liver insufficiency. I don't think you should write. I don't think all of you should listen. Basically, ask questions if you can. Okay, stop the book. You can read it whenever. So, why do you do an ammonia? You do an ammonia first to understand whether there is an undiagnosed pathology in the liver. Because one of the commonest causes of ammonia generation is the liver not working well. Alright. And why does that occur? Why does the liver not work? This is one of the reasons you want to do this. Okay. What is the second reason? And why does that occur? Why ammonia goes up when liver is not working?
So enzyme required for the cycle because leading liver. So
There is no.
Peripheral vasodilation leading to shunting.
But why? Ammonia is going up.
There is a problem in the cycle of elimination of.
Now let me give you an example. Okay, if I take an animal, I'll give you an example. If I take an animal, okay, and now I remove the colon. And now I fire up the liver. I have taken an animal, okay, and I have done a total colectomy. That means now this animal, say this dog or this cat, does not have a colon, okay, and now I go ahead and fire the liver. Matlab I spoil the liver also. I do something to make it as hepatic failure. That I spoil the liver. I maybe infuse hepatitis virus or something like that and spoil the liver. Or I ischemically make the liver spoiled. Right? Now this patient's ammonia may not rise. Now give me an example as to why ammonia is coming up. So yeah, so it's actually the answer is you have the colon. Okay, how is the circulation of our body? If I would put the circulation of our body for GI tract, okay, you have the foregut, you have the midgut, and you have the hindgut. I'll sometime take this lecture for you. Foregut, midgut, and hindgut. Okay, when you say foregut, we're looking at esophagus to second part of duodenum, from duodenum to jejunum, ileum, all that comes down here, and then colon comes there, up to anus. Okay, from colon to anus comes here. Right, now how is the circulation here? Here, celiac artery, superior mesenteric, inferior mesenteric. Right, celiac artery, superior mesenteric, inferior mesenteric. Now what is also happening is, after it actually supplies the blood from here, the vein that it goes to is the portal vein. All of them are connected to the portal vein. So this is the artery of the foregut, midgut and hindgut. This is a very schematic representation, okay? Foregut, midgut, hindgut. You have artery, superior mesenteric, inferior mesenteric. So celiac trunk, superior mesenteric, inferior mesenteric. And all of them drain into the portal circulation. This means to say all the dirty stuff from the colon is now going into the portal circulation. Simple? This is simple till now? This means to say there has to be a mechanism from which this portal circulation filters out all the bad things. There has to be a mechanism. What is that mechanism? That mechanism is the liver. That mechanism over here is the liver. That is why the portal vein needs to empty into the liver, and from the liver all the dirty stuff gets off and it gets into the inferior vena cava and then goes back into the right atrium. You're understanding? So this is the schematic. Simple? I'll just explain this once more. You have a foregut, you have a midgut, and you have a hindgut. This entire place is now laden with a large amount of bacteria. What are these bacteria? These are those bacteria that actually are splitting the urea. When they split urea, they form ammonia and carbon dioxide. When they split urea, they form ammonia and carbon dioxide. This is what really occurs. It forms ammonia. Now this ammonia is something that needs to go out. It is not something that needs to be there. How does it go out? How does it go out is, it moves from the artery, from the vessel into the portal vein. And from the portal vein, it enters into the liver. The liver has got a fantastic architecture. How does the liver look? If I were to actually draw the liver architecture to you, it's fantastic. So you have a hepatocyte. This is not part of exams and all, but you must understand this because it makes it easy. Okay. So you have hepatocytes. They are very closely related to each other. Okay, hepatocytes. Okay, hepatocytes. All right. And you have these cells that are lying in the middle, which are actually the Kupffer cells. You have the Kupffer cells. So I would call this as part of the Kupffer cells. These are called the sinusoids, and this is the bile. That is why in a hepatic lobule, which is hexagonal, you have a triad. You have a triad. You have a hepatic artery, you have a portal vein, and you have a artery. Right? You have a hepatic artery, portal, bile duct. And here you have a venule. Okay, so if I were to actually put all these and connect all of these together and then take a picture of this is what you're going to see. You understand? So what is actually happening? The bile and vein is going opposite to each other, just like dialysis. Bile supply and vein is going in the opposite direction. So it becomes very easy for them to interact with each other. You understand? It's very easy to interact with each other. That's why when vein it is draining into this, from here it goes into everywhere else. As it's draining into this, all the exchanges takes place. You understand? All the exchanges takes place, and that's how the Kupffer cells that are supposed to be here, Kupffer cells which are there, will actually take up all the problems that come in. All the problems that come in from the vein here is taken up by the Kupffer cells. Now let's take the situation where the liver is spoiled. If the liver is spoiled, what is happening? First of all, there may be a physical obstruction. There may be a physical obstruction because liver is spoiled. No longer this canaliculi are the way they are looking. Hepatocytes are damaged. The flow is not okay. Since the flow is not okay, the bile is not moving well. You start getting bile inside your body. You understand? Since the flow is not okay, the liver is ekdam kharab. It needs somewhere where the blood should go. So the blood doesn't go this way. That's why it opens up portosystemic collaterals in the esophagus, in the anus. It opens up portosystemic collaterals because the liver is not working anymore and it is physically obstructed. Since it is physically obstructed, it opens up collaterals all over. It opens up to the esophagus, maybe near the caput medusae, near the umbilicus. It opens near the inferior epigastric, inferior mesenteric and the anal verge, and that's where you get piles, right? So you get portosystemic collaterals. Now what has happened here? What has exactly happened? The blood that actually needs to go to the liver is now not going from the liver. It is now going from the inferior mesenteric, superior mesenteric portal vein. From the portal vein, where is it going? Directly into the systemic circulation. So is it getting detoxified by the mechanism that we discovered? No, it is not. So the entire blood is now going into the systemic circulation. You got the point? And that's why what happened to the ammonia?
Interesting.
Simple? Any doubts? It is very simple. This is to make it very simple. I am showing you. This is the way it is, right? So the maximum ammonia that is getting produced is actually produced in the gut by the urea splitting organisms. Got a huge number of organisms: Klebsiella, E. coli, bacteroids, so many other organisms, enterobacters. Everything are there in this gut, which actually takes splits up the urea into formation of ammonia. It is that ammonia that needs to be detoxified by the liver. Unfortunately, if the liver is not working, that everything spills into the systemic circulation. And since it spills into the systemic circulation, the body's ammonia starts going up. So for certain I can say that most probably, if the ammonia is going up, I have a problem with what organ?
Liver.
That is very high likelihood. Other way around, there is also one way that this this particular urea is converted into soluble products. Soluble products. You understand? And this ammonia has got an excretory mechanism even through the soluble urinary tract. It has got a mechanism of excretion through the solitary, though the maximum is the portal circulation. It still has got a small other mechanism where it can go from the urinary tract. And that is why if you have distal renal tubular acidosis, acute urinary tract infections of any other nature, that can also cause your ammonia to go up. You're understanding? The third thing, one of the reasons that ammonia can go up is because maybe you're given an excess amount of urea, excessive amount of urea that comes inside, that this mechanism is unable to cope up with it. That can also cause the ammonia to go up. Clear? I can diagnose. So now you've understood the genesis of ammonia at least. The genesis of ammonia. Apart from this, there are some small mechanisms here and there, but this is what basically is occurring. Clear? Till now clear? Okay. So now that you have, one of the reasons that you want to do is you want to diagnose maybe occult hepatic cell disease, which I didn't know. So I get an ammonia that's high. I did an ultrasound. I got cirrhosis of the liver. Now I'm putting 2+2 and saying that this is probably, or I went back and I looked at the patient. Patient has basically had a history of acute poisoning with paracetamol. I find the ammonia to be high. Now I can correlate. Okay, this is paracetamol poisoning causing acute hepatic failure, which is causing the ammonia to go up. Clear? Or ischemic necrosis has occurred because there has been a vascular insult for a long period of time. That has basically caused the ammonia to go up. Okay, liver getting spoiled, ammonia. So that is not going to correlate. And however, when the other reason to do this ammonia level, the other reason to do the ammonia level sometimes is also to say that whether this patient has got a very high chance of raised ICP related problems. So if I have an ammonia level, more than 200, okay, more than 200, the chances of having cerebellar herniation is very, very high. The chances of having cerebellar herniation is very, 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 very high. Okay, anything above 150, I'm worried. Anything above 150, I'm worried. Okay, so I might think it, but you must also understand the other part of the story, that normal ammonia level does not signify that patient does not have hepatic encephalopathy. Clear? One way of the story is if the ammonia is very high, if the ammonia is very high, more than 150, maybe nearing 200, I have a slight feeling, I have a clear indication that this patient has got a very high chance of raised ICP and cerebellar herniation. Okay, but very high chance of cerebellar herniation, very, very high chance of cerebellar herniation. Clear? So all my treatment would be looking towards ICP. You know, everything that is going to happen is going to die because of an ICP. Forget about everything is going to die from ICP. Right? Everything will go towards that. That's why when we have patients whose ammonia levels are elevated, what do? You give 3% saline, 300 ml. You quickly intubate this patient to lower the ICP. Don't just wait with that patient just because he's maintaining an airway or something like that. Here the treatment is directed towards raised ICP. So I would intubate, I would sedate, I would give 3% saline, I would monitor the optic nerve sheath diameter, I would put an ICP bolt, I would do a lot of things to get the ICP down. You understand why would I use an ammonia? However, when I want to do an ammonia level, there are certain small caveats. How do I do it? So how do I really do the procedure? If I want to send an ammonia level, how to do it? The 2-3 important things that you must understand is, don't tell the patient, ऊपर नीचे करो, हाथ ऊपर नीचे करो, अच्छा ऐसा प्रेस करो और फिर do not tie a very tight tourniquet. Do not tie very tight tourniquet, because you know one of the places from where ammonia comes out is from the muscle. It's from the muscle. So you tie a very tight tourniquet, you probably not get proper levels from the ammonia. Second thing is, if you want to do the test, run the test quickly. The later you run the test, the more the problem. The more the sample is kept in room temperature, more the problem. So these samples are like ABG samples. You need to actually do it quickly. So I send an ammonia level, मैंने collect करके बाजू में रख के लेके जा रहे हैं, but that is not how it's supposed to be done. An ammonia sample has to be a refrigerated sample or on an ice sample that goes and gets into the laboratory quick so that it can be immediately processed. You cannot have the ammonia level. So that's why this is something that you should be very careful about. Ammonia levels. Otherwise, the interpretation become very, very difficult. Right? Now, when we started, Dr. Niharika talked about acute and chronic liver failure. Okay, so let's just understand this phenomenon a little bit more better. Okay, we'll come to the treatment of this together because it's probably the same. Okay, the treatment of ammonia. So, how do you diagnose? What is the difference between an acute liver failure and chronic liver failure? What would be the difference? If I were to ask you the difference, what would be the difference? Any one or two ideas as to what could be the difference? Let's take clinically. Let's take clinical as one of the ways to differentiate.
Underlying liver disease.
Sorry?
Underlying
Clinical. So let's say clinical.
And,
So we are not talking about pathology.
Diabetes.
Clinical. So symptoms wise?
previous history of hepatic injury.
Symptoms wise? What will this patient be? Or history wise? Is there, okay, so let's take history. What history? So your history say a patient has got previous history of chronic liver disease. Okay. That's no brainer there for us. That's confident. But that's not something I'm really.
Duration of symptom.
Yeah. So what is that?
So if it's like less than 7 days, then we call it.
No. That is the same for acute liver failure. When you say hyperacute, acute, and subacute, but the entire thing is acute only. When you say duration, what she is trying to tell is when I want to say acute liver failure, I can divide the liver failure into hyperacute liver failure, acute liver failure, and subacute liver failure, where hyperacute is less than 7, 8 to 28 is acute, and more than 28 is subacute liver failure. That is what doctor is trying to tell. Okay. What am I? The history. So the history here would say that this is an abrupt onset encephalopathy. This would be an abrupt onset. That means to say the classical example is of drug ingestion. Okay, that means a patient who's taken 700, 500 tablets of paracetamol comes to you and abruptly becomes unresponsive, irritable, and whatever. It's an abrupt onset. Whereas here it is a small smoldering onset, dire, and then an insult comes and then he goes down. So there would be a history that says that I'm not well for so many days, I'm having a sleep-wake cycle alteration. All these things would come into that, he's not okay, and then dire, he goes bad. Chronic liver failure. That is one of the prime differences between acute liver failure and chronic liver failure.
And signs of portal hypertension will get
It will be here. So when you say portal hypertension, it will not be seen here because we just discussed this, that acute, when you have a gut like this and dire, the liver is not working well, there would be development of photosystemic collaterals. So these photosystemic collaterals would actually be seen only when there is problem. So if the patient has got a history of bleeding piles, if there's a history of hematomesis, okay, you see capillary over there, this goes in favor of saying that this is probably chronic liver disease and it is not acute liver failure. Clear? Clear? What about laboratory? What about laboratory? So laboratory, what is the problem? Which cycle is the problem here? Which cycle is the problem? Urea cycle, right? So because of that, the urea production is only low. The urea has gone low. The urea is low. So here, the urea will be low. Because the urea is low, the ammonia may be low or normal. Are you understanding? Whereas in acute liver failure, the urea production will be normal. The ammonia will be normal or high. It will not be normal to be high, in fact. The ammonia will be normal to high. Are you understanding? So there is a difference between both of these. Right? Clear on this? Because the urea production is also low, it could be normal. Ammonia could be normal. You got the point. It need not be always elevated. It could be normal also. You understand now? Clear? Urea will be classically low because it's not producing itself. Liver is not producing that. Clear? So that is, there would be these kind of differences that you probably get in acute. Here you might get an albumin that is on the lower side. Here you may not get an albumin on the lower side. You may get the albumin to be normal. This is acute. This is chronic. Here the patient will go into ARDS. In acute liver failure, the patient will go into ARDS. Why? Because it's an acute episode. It's an acute episode, extreme systemic inflammatory response syndrome. They will go into ARDS. Whereas these patients will not be in that ARDS phase. In these patients, what they will have those photosystemic collaterals. What is that called? Hepatopulmonary syndrome. So here you have ARDS. Why is this ARDS coming? It is an acute phase. In an acute phase, there are all problems that are occurring which include systemic inflammatory response. this comes to the question. This means to say that both these, this more than this, has a higher chances of sepsis when you said. Why? Why? I will not be wrong if I start antibiotic on a patient of liver failure. Why?
To rule out SBP.
Why will a patient of liver failure have a high chance of going to SIRS and sepsis? Sepsis is what? Dysregulated response.
Inflammatory response service.
Dysregulated
Immune response.
to a
infection.
what is this? You all don't know different sepsis? None of you are? Read out the definition. I can't believe it, you all don't know sepsis definition. Huh? So what is actually happening here? So let's go back to let me draw the liver back, okay? So what did we say? That all the badness coming from the liver, okay, is detoxified by the liver. All badness from the circulation detoxified by the liver. So one of the things that is coming from all this place is lipopolysaccharide, LPS, lipopolysaccharide. Okay, one of the things that are coming is lipopolysaccharide. Liver also produces something called as complements. These are important products. What are these complements? These complements are responsible for your neutrophils to work very well, for your macrophages to work very well. You're understanding? Your macrophage, phagocytosis, neutrophils, all that works beautifully well because you have complements. Okay, these are products that are produced by the liver, right? So in short, when you have a liver cell failure, these complements are not produced well. Since these complements are not produced well, one arm of your infection prevention, that is use of neutrophils and macrophages, they are not working pretty well. You understand? They are not. You understand? No? They are not working very well. Since neutrophil phagocytosis is not good, macrophage is not working very well, there is a chance of sepsis coming in. Organisms can't be taken out. Similarly, when you have lipopolysaccharides which are getting produced on a regular basis inside the colon, inside the gut, this is now bypassing the portal circulation. This is removed by the Kupffer cells, and that is why what happens? All these lipopolysaccharides are finding their way into the systemic circulation. What does lipopolysaccharides do? They actually causes the release of nitric oxide synthase, nitric oxide. And because nitric oxide is increasing, that's why you have a hyperdynamic circulation that is developing, a vasodilatation that is developing. Clear? You're understanding? Huh? So that means these patients have higher chances of going into
Sepsis.
And what is sepsis? Dysregulated host response to an infection. Dysregulated host response. Now, because of this, the host response is absolutely not there. It's dysregulated. That is why every patient is dysregulated. Dysregulated, what is the complement will go, macrophage will come, kha jayega. Similarly, lipopolysaccharide will go, portal circulation will take it up, theek ho jaye. It's not regulated anymore. That's why dysregulated host response occurs to sepsis. Clear? Clear? Everyone is clear here? That's why if a patient of acute and chronic liver failure comes in, my first thing in my mind would be, is this sepsis? Is this sepsis that's causing this? Now, unfortunately, the usual parameters that we will use to diagnose sepsis does not work very well. In the best of the best centers, you may do SVO2. In the best of the best centers, you will do something called SVO2. What should happen to the SVO2 normally? What should happen to the SVO2 normally? Normally what should happen is, the mitochondria should not take up that SVO2. There is cell failure, no? What is happening? Artery हो गया, vein हो गया, right? Artery से जा रहा है, mitochondria क्या कर रहा है? Oxygen ले रहा है इधर. तो अगर हम 100% ऑक्सीजन यहाँ से ले रहे हैं तो 25% लेता है, बचता है 75%. This is what our normal circulation is. Our SVO2, that if I take my blood from my central line and send it, I will get SVO2 as 75% saturation. I'll get 70%. You understand this much? Huh? You understand this much? So if I were to actually be in very severe sepsis, the mitochondria is unable to take the oxygen. Mitochondrial failure हो रहा है इसमें. समझा? ऑक्सीजन ले नहीं रहा है वो. Since it is not taking oxygen, यहाँ से अगर 100% जा रहा है, यहाँ से 5% निकल रहा होगा. बचा कितना higher ना? 95%. Okay, that's a diagnosis of sepsis. That's how we can actually figure out sepsis. Very severe septic shock. You understand? But what is happening over here? Here, what is happening, unfortunately, is we cannot diagnose sepsis like this. Why? Because there is portosystemic collateralizations. So, this is not going through this mechanism only. It may be going directly from here to here by a tube. You are understanding? Are you getting the point what I am trying to tell you? Clear? So you have a problem with using SpO2. So we don't use SpO2 in our hospital. But initially we could actually figure out SpO2 to diagnose, to in fact to give a clue as to what is happening to oxygen consumption. We can't do that here. So there's a problem. SpO2 we can't use. Though we are not using SpO2, so that's why you're not basically too much surprised by this thing. The second thing is lactate. So we normally look at lactate. One of the definition in septic shock, when you look at lactate, is more than 18 milligram per dl, more than 2 millimoles per liter. That is there in the definition. Unfortunately, lactate here is not because of the sepsis related entity, it is because of the liver not working properly. So you can't use the lactate anymore. Even you can sometimes in one of the definitions of sepsis, they say you may want to see the improvement of lactate after your resuscitation. You may want to see an improvement. It's not said a high, strong recommendation, but you may want to see an improvement in sepsis by looking at your lactate coming down. Right? Unfortunately, can we use that lactate here? We again can't use it. You understand? So for diagnosing sepsis, we don't have two important things that probably we may have used otherwise. So that's why it becomes a very tricky situation when you have sepsis, that is one of the causes for acute or chronic liver failure. Are you understanding? One of the causes for acute chronic liver failure is sepsis. Now the diagnosis of sepsis thus becomes difficult. Are you understanding? It thus becomes difficult. You are very difficult to understand. They already have hyperdynamic circulation. They already are vasodilated. What more is there? We after diagnose sepsis by saying, okay, there is immune paralysis. There is vasoplegic state, but that is already there in this. That's already there in this.
Collaterals get formed in chronic.
Yes, so that
acute,
it will not be there.
So we can stick to
In acute liver failure, there is a difference. That's why here sepsis is a different situation. Here sepsis is a different situation. Here you may want to use SpO2. Here you cannot use SpO2. You understand? Here you can't use lactate, but SpO2 you can still be able to use because there is no collaterals coming in. You are understanding? So that also is an important point to diagnose between acute or chronic liver failure and acute liver failure. Clear? Clear on this? So sepsis becomes a problem. Clear on this? Now, so if you have a chronic liver disease coming inside, now we will start by saying ammonia, right? So what does ammonia do to the body? Now that we know that ammonia can cause a problem, what does ammonia do to the body? What exactly is happening? We are so much talking about ammonia being high. What happens with ammonia? So why to do we have done? How to do we have done? How to do the test we have done. Now, how to interpret this test? How to interpret also we did by saying what are the high levels and what happens with that. Now, what is the problem? What is the problem with ammonia? Do you think ammonia is a problem? Anyone? Alia, you think ammonia is a problem? Why? How? So you're right. You're absolutely right by saying that ammonia can cause cerebral edema. A very important term, cerebral edema. Okay, how does it cause it? What really is occurring? Why does it cross the blood-brain barrier? There is no reason for it to cross the blood-brain barrier. How can ammonia cross blood-brain barrier? Ammonia doesn't cross blood-brain barrier. Blood-brain barrier is a barrier. So how does ammonia cause this problem?
Ammonia get converted into NH4, which damages the astrocytes.
So what happens to ammonia otherwise? If ammonia is there in your body, what is happening to ammonia? if it is not being utilized by the liver and getting out by the liver, what happens to the ammonia? Ammonia gets converted into what product? Glutamine. So ammonia gets converted to glutamine. Okay. Now this glutamine enters into the astrocytes. They enter into the astrocytes. Okay. Once they enter into the astrocytes, it becomes highly osmolar. Highly osmolar. So what happens? It absorbs water inside and the astrocyte swells up. It absorbs inside and the astrocyte swells up. Okay, now you must understand in the brain you have only three things. You have got blood, you have got brain matter and you have got CSF. You are not increasing or reducing the CSF, you are not increasing or reducing the blood, but it is the astrocyte that is swelling up and the maximum amount of tissue that we have in our brain is astrocytes. Okay, so it is known to swell up by 127 times. It is known to swell up by 127 times. 127 times raised ICP. Okay, that is why patients have raised ICP. This is one of the reasons. But then, it is not only raised ICP that we are talking about. We are also talking about a patient that is getting slow. We are also talking about a patient that is lethargic. When you see the encephalopathy grades, I understand raised ICP will come when there is coma. Patient is in comatose situation. Patient is extremely down. That is raised ICP. You cannot have raised ICP when a patient is sitting in front of you talking to you normally or having sleep wake cycle alteration, right? When you see grades of encephalopathy, this is raised ICP comes last, no? Right? When you have a grade 1, grade 2, grade 3, grade 4, you have West Haven criteria for grade. There are 2-3 criteria of which we know West Haven criteria. Where what is the West Haven criteria clinically? So when you say euphoria, what is happening? So the small classical difference between this small clinical difference that you can probably see is there is an addition function that is not working. Then in the second stage, the subtraction function is not working. Addition and subtraction. That's why when I talk to patients, I say 2 plus 2 क्या है? And there I said 4 में से पूरी गल कितना आता है? You understand? So as you progress, there's addition subtraction may be working, the addition is not working, your subtraction also not working. You understand? So that is one thing. So euphoria, then comes lethargy, then comes somnolence, and then comes coma. Okay. So in the first stage, you may have just some jerks and some tremors. This is all that you will have on the first stage. Some jerks, some tremors, or some alteration of sleep-wake cycle. Patient is sleeping during the day and awake during the night. Otherwise normal. Okay. When you come to grade 2, they start sleeping, and they have complete disorientation, time, place, and the subtraction function that goes off. Disordered subtraction function. Right? And when you come to grade 3, they become agitated. They become delirious, and then comes to comatose stage. So the last 2 stages, stage 3 and stage 4, I can think this is the pathology. Last 2, like grade 3 and grade 4, I can think of this as the pathology. You understand, na? But what about grade 1 and grade 2? There something else is occurring. There is an ammonia that's going up. There's something else. So what does occur? So what is occurring is when the ammonia goes up, what has happened is glutamine has gone inside. Why do we talk? Why do we do things? Why do we think? Why do we do things? Because we got 2 important hormones in our body, neurotransmitters, dopamine and serotonin. That's why if you see when dopamine goes down, patient becomes like Parkinsonism. You're understanding, no? When serotonin goes up, patient becomes mad. Clear? So dopamine and serotonin are 2 very, very important neurotransmitters that are keeping you on. They are keeping you on. You understand this? What is happening, unfortunately, is because this increase of glutamine has taken place, it is the wrong amino acid in the wrong place. Suddenly, the brain doesn't understand what to take and what not to take. So rather than actually producing dopamine and serotonin, they start producing some other enzymes only, like phenylalanine and things like that, and noradrenaline. They may make something like noradrenaline in the brain. So all these things causes these kind of encephalopathic problems. You understand now? So it's not really that the blood-brain barrier is gone through by ammonia. Okay, the ammonia causes a change in the osmolarity inside the astrocytes, which creates a problem in the transport mechanisms. And the usual transport mechanism is of producing dopamine and serotonin. They stop doing that and they start producing some other neurotransmitters called as false neurotransmitters. And one of those false neurotransmitters that we have is probably an increase in noradrenaline or an increase in something like phenylalanine. Okay, and that's what causes this this patient to become a little bit somnolent and not okay and things like that. Okay, so this is the second proposed, first and second proposed mechanisms that ammonia causes, which may cause problems inside the brain. The third thing is, what you must understand is, when these things are swelling, what is going to happen if initially there was the artery that was very close to the neuron. When the artery is close to the neuron, because of the swelling, there is a huge amount of swelling. The neuron is still here, but the artery has gone back. Since the artery has gone back, the nutrient going inside that particular neuron is reducing because it's got a longer time to go inside. It's not bathed, right? So the nutrient pathway into the brain is also reducing. That is why these patients, we should never allow hypoglycemia. Because brain requires the glucose, and unfortunately by this mechanism, the hypoglycemia, if it happens down there, it will be much more difficult on top. Are you understanding? That is why hypoglycemia is something that we must at any cost avoid in patients who got these kind of problems. And that's why we don't want to reduce carbohydrate load also. There are many reasons why you don't want to reduce carbohydrate load in nutrition. This is one of the reasons. तुम carbohydrate कम मत करो उसको calorie impact ज़्यादा दे दो. 25 to 30 kilocalories. You want to give 35 kilocalories, but give him that carbohydrate. Give him a larger amount of carbohydrate. You understand? Why do you want to give it a larger amount? Because you know there is a problem in the nutrient metabolism. You understand? There are other reasons also, we'll come to that also, as to why you want to give carbohydrate. But this is one of the reasons. You understand? Nutrient metabolism has gone down. Clear on this? Clear on this till now? So nutrient metabolism has gone down. Blood supply has gone down. You have cerebral edema that is developing. The neurotransmitters are changing, and that is possibly causing the problem that you have with respect to encephalopathy. Clear? Clear on this? So how do you get this out now? Now that you know the how do you treat these cases? For example, if I want to get this ammonia, let's just concentrate on just ammonia. Okay, since this is something that we're talking about, how do I take this ammonia out? क्या करें?
Make your colon work more.
Sorry?
Decrease production.
More, sir. Why colon eliminate it more and more. Like, don't keep it like inside.
So what to do?
Conversion of urea into ammonia, should avoid that.
So what to do? Correct.
Should eliminate it by.
So try to increase the transit time. That is what you're trying to tell.
Yeah.
If there is something in the colon, let it just flush out.
Let's go first.
If there is something in the colon, let it just flush out. So what you're talking of is bowel catharsis. We're talking of catharsis. That's called catharsis. When you say catharsis, what is happening? You give something, it flushes out and becomes fine. Unfortunately, then peg leg should also work. Unfortunately, if you give peg leg, what happens in peg leg? You are emptying the colon. It's a much faster mechanism, right? You put in the rice, you give peg leg, let it come out, patient will become fine. Unfortunately, that is not the only mechanism, or in fact, that is very small as a mechanism to get the ammonia out. Clear on this? Clear? You understand? Now, otherwise, what should have worked? Peg leg should have worked. Are you understanding? Clear on this? Peg leg should have worked. No, peg leg is not working. Why is it not working? Because it's not that only as the effect. Okay. So that's why you were talking about lactulose, saying that maybe we can give lactulose, isn't it? Lactulose will cause catharsis. But that's not the. How does lactulose cause everything? So lactulose, one mechanism you say is catharsis. So let's take lactulose. If you want to use lactulose, for example, one mechanism is catharsis, no doubt. But that is not the only mechanism. You understand now why? Because otherwise peg leg would have been working. So when you say lactulose, okay, one mechanism that you said was catharsis. Then, any other thing? Any other thing? Any other thing? So you did mention a cycle. In that cycle there was alpha ketoglutarate dehydrogenase. Right? Alpha ketoglutarate, what happens with that? So the presence of that makes your cycle run. The presence of that makes your cycle run. Yeah, alpha ketoglutarate dehydrogenase. right? The presence of that base cycle, that's why that case comes to ammonia and all these things. Now what happens with, and that cycle works better when the pH is alkaline. That cycle actually works better when your pH is, what does this do? It actually, lactulose is actually disaccharide. Okay, what it does is actually donates an increased hydrogen ion there. Since it donates the hydrogen ion, the ammonia gets converted to ammonium. Okay, and that causes these patients to have less ammonia and more of ammonium, which actually gets excreted out. Right? The third thing is, what we know is that most of these urea splitting organisms are bacterioids like Enterobacter. They thrive on proteins and amino acids. That means you give them proteins and amino acids, they produce more ammonia. They'll work much more better. Okay. Now what happens over here is, the moment you are giving lactulose, you are reducing that particular organism. Okay. And on top of, and so the other organisms. And so if you give carbohydrate to them, they will not produce as much. Now what are you doing here? Disaccharide. Disaccharide is what? Carbohydrate. Are you understanding? So your disaccharides over here. This is but carbohydrates, right? This carbohydrate. So now what are you giving? You are giving larger amount of carbohydrate. And where is this carbohydrate going? This carbohydrate is reaching the colon because this is non-absorbable. Lactulose, after 50 milligrams, after you give 50 milligrams of carbohydrate, after 50 milligrams of lactulose as a total amount, nothing can get metabolized. So you can't give 5 ml of lactulose and 10 ml of lactulose. You have to give big amounts of lactulose. When you give big amounts of lactulose, after 50 milligrams have gone inside, nothing can get metabolized. So this goes unabsorbed into the colon. Since it goes unabsorbed into the colon, now these disaccharides are lying where? It is lying actually in the colon. Pure carbohydrate is reaching the colon. You understand? And because otherwise pure carbohydrate will not reach the colon. Otherwise before only it get absorbed, no. You got a whole GI tract. Uske pehle absorb ho jayega. Now what is happening? All these carbohydrates are now reaching the colon. Once it reaches the colon, what is happening to this bacteria? The bacteria starts getting carbohydrate. Now this bacteria does not know what to do with the carbohydrate. And it stops doing that protein thing and starts taking carbohydrate for its nutrient metabolism. You understand? Since it's taking carbohydrate for nutrient metabolism, the amount of ammonia generation actually comes. You understand? Clear on this? This means that if I keep lactulose down there, it is much better for my patient. That is what we now want to do, a retention enema of lactulose. Are you understanding? If I keep it right there for a while, these disaccharides will work right over there, and that will cause the production of ammonia to actually come down. Clear on this? Clear? Any doubts on how lactulose now works? So it's got a couple of effects. It's not just one effect. There's a couple of effects that it works on, and that's the reason that you probably are able to get around this. Okay. Now we go back to, now that we know what's ammonia and how do you treat that ammonia, this is one of the ways. There are other ammonia products, there are other things also you can use. There are ammonia scavengers and all that you can use, sodium benzoate and things like that, but that's not available as of now. Okay, that's what we don't use it. Okay, so we are just doing the common mechanism, lactulose. Okay, common mechanism, right? Any doubts till now? Any doubts? So now you've understood how to tackle ammonia, right? How to tackle ammonia. Now the next question is, what are the investigations I'll send when he actually said acute on chronic liver failure? We understood the symptoms. We understood the symptoms that said that you may probably have hepatopulmonary syndrome, you may have hepatorenal syndrome, you may have sepsis, you may have so many other things that probably clinically with already a history that says that he already has chronic liver disease, or the patient has got a smoldering course of over a period of time not feeling okay and then having these problems. So now what are the investigations you want to send in these cases? For that matter, what is the etiology of acute and chronic liver failure? Now for example, you have a diagnosis that this patient has got a chronic liver disease like Abhijit said. Patient has got a history of having a cirrhotic liver. Okay, and now patient has come in with acute and chronic liver disease. So what are the diagnoses that you will have or the etiologies that you will have? What will be the etiologies? say a patient has come to you, I'm again going to repeat the question, a known case of chronic liver disease since last 10 years, okay, now has come to you with a lethargy, okay, now the lethargy could be anything, it's not necessary that it's raised ICP, it could be anything, right? It could be anything, that lethargy, that is, it could be just sepsis for that matter, right? So what are the etiologies that you think of when a patient comes with acute or chronic liver failure? So whenever you have etiologies, you must always remember to categorize them in different parts. If you categorize them into different parts, you'll understand it better. Okay, so vascular, infective, neoplastic, drug-induced, idiopathic, congenital, trauma. This is the method to remember it. Okay. So whenever you have any etiology, anything that you think about vascular, infective, neoplastic, drugs, idiosyncratic or idiopathic, congenital and traumatic. So when I say, tell me the reasons why a patient can go to acute or chronic liver failure, you start thinking like this. What could the vascular cause? It could be maybe LV failure and back pressure. It could be ischemic hepatitis because of shock. Vascular aa gaya usme. It could be portal vein thrombosis that has developed suddenly, which has caused this particular problem. Quality of vascular causes. Infective, I'd say hepatitis, a virus, maybe a CMV virus, maybe a EBV serology, maybe HSV virus, maybe HCV virus, anything, virus. When I say, or it could be just sepsis, bacterial sepsis that comes in. When I say neoplastic, I'll say formation of a lymphoma, formation of hepatocellular carcinoma. When I say drugs, I'll say AKT, I'll say paracetamol. Acute or chronic can develop because of this. When I say idiopathic, it could be anything. I mean, idiopathic is idiosyncratic drug reaction. For example, you have taken an antipsychotic. When you say congenital, it may come to Wilson's disease or something, some congenital problem that you basically have. And then traumatic because of capsular hematoma or painful liver cell injury. So when I ask a question like this, if you divide this into something like this, Vendic, the Vendic definition, okay, it's very simple to remember. You can do most of your things. You can actually talk like this. Most of the things that you are going to talk in your exams can be talked about like this, and you can also think like this. That is why when you come to this, what will be your investigation? Sister, give me 5 minutes, sir. 5 minutes. What would be your investigations here if you have hepatic failure? And let's have a target. You said CBC. Why do you want the CBC? So these are targeted investigations. Okay, we are not really talking of every investigation. We can do everything as a routine. But why you want to do a CBC? So it's not going to work because you may have WBC count that is elevated or low or whatever. Okay, sepsis, you want to look at sepsis per se, but WBC is not a great indicator. Eosinophil count, because you're looking at etiology here, right? So eosinophil count. Why the eosinophil count? Because if you have an idiosyncratic drug reaction, an allergic reaction, there is a possibility of the eosinophil count going up. Okay, but on the differential count, if you have a neutrophil that is going up, normally in these cases the neutrophils will not go back because complements. Okay, the complement system is not okay. That's why the neutrophilia is not occurring. These patients will not have neutrophilia. 60, 50 neutrophil count will be there because complements are not working. You're understanding the difference. Okay, it may not be necessary that the neutrophils will go up. So what do you think? It's only in the case of pregnancy. So one of the causes over here is pregnancy also. Say pregnancy that causes pre-existing CLD, which is basically causing HEP syndrome or things like that. So in pregnancy, you may have a neutrophilic predominance. Pregnancy is one place where you can have neutrophilic predominance, right? So targeted investigation, CBC ho gaya. Then targeted, I don't want to say any general investigation, okay? Targeted, sorry? PT, INR, right? So, but what will that difference tell you? Nothing. I'm looking at etiology. Tell me, looking at etiology, what you'll like to do?
Hepatitis A, E, viral markers.
So let's go one by one. Vascular, what do you want to do?
We'll say triple H.
Portal vein thrombosis.
Okay, portal vein thrombosis. You want to look for portal vein thrombosis and back pressure, LVF,
echo,
2D echo. Simple, no?
Yeah.
You want to do an ultrasound because you know this is chronic liver disease. You want to find the etiology. I want to do the 2D echo to see for back pressure changes. I want to do an ultrasound of the portal vein to look for portal vein thrombosis. I want to look at congestion, for everything about congestion. That's about vascular. Let's go here. 3. I is what? Infective. Blood cultures, yes. Then?
Hepatitis A, E.
So which of the viruses will cause this? Usually the virus hepatitis B. Okay. Usually virus hepatitis B. So what do you want to send here? If I have been infected 10 years ago, also my HBsAg can be positive.
EAG. Infectivity E.
E surface.
Core. So what you're supposed to send is HBC core antibody. समझ में आ रहा है? HBC core antibody, HBV DNA, hepatitis virus viral DNA, and IgM hepatitis. HBsAg you can send if you want. You can send surface also HBsAg. But this core is very important. IgM should be seen. Okay, because if the IgM is not seen, it could be just a past hepatitis B. You understand? The core is important here. HBC core. Okay, then on the viral front, the other virus that you can send is HAV. HEV usually is acute liver failure in pregnancy. Acute liver failure pregnancy. But we're talking of a chronic liver disease coming in. Hepatitis E less likely, hepatitis A more likely. IgM, HAV. IgM. Right? So this is what I'm going to send here. Then comes N. N is neoplastic. What do I want to send? LDH. Because most of the malignancies will have the LDH to be up. Okay, that's why LDH will come here. When you said ascitic fluid, here comes the infective etiology. So in infective etiology, yes, ascitic fluid, the maximum possible you must send for ascitic fluid. Over here, that's right, is ascitic fluid. Then idiopathic. Idiopathic is not much we can do. Idiosyncratic drug reaction आता है वो. So drug reaction eosinophil count आ गया. Then इसमें nothing is there. But idiosyncratic also you can talk about is copper levels, ceruloplasmin levels, Wilson's disease, वो सब उधर आएगा. So copper levels, ceruloplasmin levels. We also forgot Vindict A. इसमें ना idiopathic में also you put autoimmune. So here will come anti-SSMA, smooth muscle antibody, anti-smooth muscle antibody, autoimmune. No, that is what? That is nothing. That is not going to tell you anything. Autoimmune means you got antibodies, like for example anti-smooth muscle antibodies. This will all come over here. You understand anti-smooth muscle? Whereas in infective you also have the viral etiology, EBV, HSV. This will all come here. EBV, HSV. You understand? So that's how you actually diagnose acute and chronic liver. This is simple. Trauma is something that is always there. Ultrasound will get it. So Vindict, got the point? So the targeted investigations are not just LFT, RFT, uric acid. You have to understand what to send. For why are you sending it? You are sending it because I want to diagnose acute on chronic liver disease. Are you understanding? Clear on this? To diagnose this, these are the things that you will probably go to look at. Clear? Because that's why when you are actually approaching a patient of acute chronic liver disease, you start by saying what is the etiology. Then you go ahead by saying what are the investigations that are required. If you have the structured way to do it only, then only you will know what is to be done. Otherwise, you will not know what you're supposed to do to find etiology. You understand? You have to be structured, properly structured. Clear? Clear? So, laboratory investigations, what you require, and what are the etiologies. Clear? So, I think, and we've already gone through how to tackle ammonia. Of course, everything else will over here will be what? In acute or chronic liver failure will not be really ICP. It will not be really ICP. It will be more of slow treatment of the cause. So if you have LV failure, it is removal of this. Ammonia, you will continue detoxification strategies. It's different from acute liver failure. What is happening in acute liver failure? Grade 3, grade 4, I'm intubating, I'm putting rapid sequence intubation, I'm trying to sedate this patient, I'm trying to give 3% saline. You got the point? Whereas here what am I doing? I'm doing everything to get the cause out. I'm trying to get the anticoagulation, I'm trying to get the the infective etiology under control, I'm trying to get that, I'm trying to remove the drugs and trying to remove, get that fine. I will be doing ammonia in both ways. But ammonia is not something, it's not raised ICP, that's my problem. I'll try to remove the ammonia because that's why the patient is having alternate sleep-wake cycles. But it's not that. So the difference is the way I manage. Clear? Okay, we'll stop for now. We'll stop. Okay. So, sorry sister, one more. Rifaximin. So, she's asked a very important question. In fact, I'll put two more things in place since you said rifaximin. So, one of the drugs that you want to use is rifaximin. Okay. Now, what is the cause of our problem? Of our ammonia, what was the first cause that we talked about?
Gut bacterial body.
The classic blood pathogen they're talking about, I mean, the big avengers are what? Klebsiella, E. coli. These are the ones that are there. And these are not those multi-drug-resistant organisms. These are these normal Klebsiella that are lying inside your abdomen. These normal Klebsiella that are lying, normal Klebsiella, normal E. coli, are there in your abdomen. It's there, it's just going out. That is the bacteria we're talking about. Those urea splitting organisms are the ones that is actually causing the water to go up. Okay, now initially what has happened was there was a famous guy who actually gave loads of neomycin. Neomycin is non-absorbable. Okay, so what happens? This neomycin goes and reaches out there the colon. Since it reaches the colon, it kind of sterilizes the colon in such a way that funnily, it is such a superb mechanism that the good bacteria doesn't get sterile. It's only the Klebsiella, E. coli and all this. This is very nice to see something like this also can occur. That only this. Otherwise, if you lose all bacteria, then you will be acolonic. I mean, there will be nothing. You will probably have a problem, right? Your gut microbiome is changed only with the pathological, difficult bacteria, urea splitting organisms to move out by neomycin. But neomycin, because of its aminoglycoside capabilities, is used for a lot of problems and toxic things that it was causing. They wanted another antibiotic there. The other antibiotic that we could think about is rifaximin. Now, rifaximin is a very clever antibiotic. It's a very small change in the ring in the chain of rifaximin that occurs, which makes which makes the gut acid or gut not to digest or not to metabolize. Otherwise, what happens? You eat something, it gets metabolized, it gets absorbed. Okay, but this rifaximin is slightly intelligent kind of antibiotic, where a small change in the chain prevents that from getting broken down. Since it's not broken down, it behaves like a non-absorbable antibiotic. So it goes from there and directly reaches the colon. And it is at the colon that it acts. Very similar to what we talked about Aculose. It goes to the colon, it actually sterilizes the gut from all these Klebsiella, E. coli and all these organisms. Beautiful mechanism of rifaximin. You understand? And that's why rifaximin is some drug that we use in acute and chronic liver failure. Why? Because what it does is it actually takes the mechanism out. And that is why there are studies that says that it reduces mortality by more than 50% and length of stay by more than some 15-20%. It reduces. Okay, so there is a change in when you use rifaximin, it also changes outcomes. And that's why it's this one drug that I want to use in my patients of acute and chronic liver failure, rifaximin. Okay, this comes to the question, how do you prognosticate these patients? So most of these patients are prognosticated by an earlier criteria called a child, pug and Turcot. You know the history about the child, pug and Turcot? So you must know this offhand because in the exams we ask you what is child's criteria. Okay, albumin, bilirubin, ascites, prothrombin time, encephalopathy. These are the 5 things that you require. Albumin, bilirubin, ascites, prothrombin time, encephalopathy. Right, 5 things. Now, you know the genesis of this. 1964 it was created. Child and pug. There are 2 people who actually did this. Okay, child and Turcot. It was not even child and pug. It was child and Turcot. So child and Turcot made of the albumin, bilirubin, ascites. Instead of prothrombin time, it was nutrition. It was encephalopathy. This was what the actual criteria was. There was nutrition there. Malnutrition being one of the parts over there. Okay, but then what happened when Turcot, they found out that nutrition is something that you cannot monitor, you cannot measure, it is very subjective. So they converted nutrition to prothrombin time. Who did that? Pug did that. Unfortunately, child and pug reh gaya, Turcot bhag nikal gaya. That's why you have child and pug only. You don't have Turcot. But it's sad. It should have been child, pug and Turcot criteria. Because child and Turcot first made it, pug just modified it. So it should have been child, pug and Turcot. And I don't know, somehow midway Turcot just moved off. So, and it is only child pug criteria, where you look at albumin, bilirubin, ascites, prothrombin time and encephalopathy. And it is divided into 3 parts. And then it is graded. Right? It's as simple as that. Unfortunately, now you'll understand that this is very again subjective. Ascites, mild, moderate, severe. What is mild, what is moderate, what is severe? Is it ultrasound guided, is it CT scan guided? Encephalopathy for you may be grade 1, for me may be grade 2, for her may be grade 3. Again subjective. Are you understanding? So this becomes very subjective again. And all the cutoffs that you have on that, prothrombin time cutoff and bilirubin cutoff, all that is very, very just made out of the thin air. They told cutoff. Someone who was a senior person sat together in 5 people to the audience and they put up a cutoff. They said, let this be the cutoff. That's how this was created way back. Except at that time, 1964, there was not evidence-based medicine was going on. At that time, they did all these things. But now we are not in that era where we're going to do, okay, so mild ascites hai ki moderate ascites hai. We might talk clinically, but that cannot be taken as a criteria to actually figure out prognosis. You are telling somebody who has got encephalopathy that he's in grade 4, so he got very bad prognosis when she is saying it is grade 1. You understand? The other thing is, those patients in ICU, you give them a lactulose, evening they'll wake up and become normal. So encephalopathy cannot even be taken as a measure, it looks like. You understand? Because what happens, patient is in coma. You give them galactulose, next day morning patient is not, next day afternoon patient is normal, talking to you. You've seen that very often, right? Normal, oriented and everything talking to you. This is seen. So how can you then say encephalopathy, high grade encephalopathy will be very bad prognosis? Difficult to say, no? So that is what they did. They sat again across the table and they looked at all the criteria that actually really means well. And that's why they came up with prothrombin time, creatinine and I think albumin, INR, prothrombin and bilirubin. These three things they come up with. Okay, and that's what the MELD criteria is. The MELD criteria. So if you want to actually prognosticate a person, the criteria to use in a liver disease is MELD, where M actually is the name of an author, but it is also called as Mayo's end-stage liver disease criteria. Mayo's end-stage liver disease criteria. Okay? MELD criteria is what we are supposed to use for prognosticating your patient. We are not using the child's criteria, though you will need to do it because MELD came in 2000, 2007, 2000, I think 2000 or something, where a child was there. So all our people who take exams have learned child's criteria, but what came in 2000 was MELD's criteria. So we use the MELD criteria. Today, if you go to a hepatologist and say that child's criteria, child B may have, child C may, he will laugh at you because you stopped using it. You're going to use what? MELD. That's why if you see what they write, MELD. You see what the liver transplant people write, these liver guys? They write MELD. Why they write MELD? Because that's what it's supposed to use. You understood why to use MELD? Because the child criteria is very subjective. You understand? And it is created from thin air. It is not from a proportional hazards model or from kind of studies. Clear? Any questions further?
So there's no point monitoring the ammonia levels.
No, there is no point now. So say for example, you have a patient who's come in with hepatic encephalopathy and you think that this may be raised ICP. The chances of raised ICP are higher when you have more than 150, right? So my treatment directions will be all based on that. So it's not, there is no point of monitoring it, but the way to interpret it is what you're supposed to think of. आज 100 है, चलो उसको lactulose ज़्यादा कर दो 80 करने के लिए. That is not how it is. Similarly, if the ammonia is normal, it doesn't mean he does not have hepatic encephalopathy. He can still have hepatic encephalopathy. You have to interpret everything properly. You understand? You give a great monitor in a patient who's a fool, it will still be a foolish interpretation. You understand? If you give a great monitor to a fool, it will be a foolish interpretation. You understand? You have to be learned. That is when you use the ammonia well. Understand? If you just take the ammonia and try to say X, Y, Z, it is wrong. Understand? You will monitor it, but you will monitor it. Sometimes what happens is, अरे आज भी ammonia 80 है, उसको lactulose दे दो और. How does that make a difference to you? Anyway, is giving lactulose. How does it make a difference to you? But the ammonia is 200. Patient is in NKF. Patient looks like optic nerve sheath diameter is dilated. I know this patient is going to have cerebellar herniation. Let me give him 3% saline. That makes a difference. I have a patient who comes drowsy and I can't understand why he is drowsy. Now I said that ammonia, it came out to be positive. It came out to be high, 100, maybe 150, 120. Now I'll start searching for the liver pathology. Because I know probable liver pathology is there. Others are also there. Distal ureter astosis is there. Urinary tract infections is there. But my first possibility is liver. Let me look at the liver. I'll not look at MRI brain and the rest of the entire drowsiness related investigations, EEG and all these things. You got the point? So you have to use it like how it is supposed to be used. Okay?
And what about the coagulopathy in acute and chronic? Like in chronic, we both procoagulant and anticoagulant factors are depleted.
Yes.
So how to handle in acute and chronic?
So the problem of INR and PTT, understand this. When you have INR and PTT in chronic liver disease, it doesn't mean the patient is coagulopathic. You cannot. It's not this way. You cannot put lines and all. You can still put lines. Because what is happening over there is that the only way you can identify that the patient is coagulopathy is by doing something that looks at whole blood clotting. And one of the investigations looked at whole blood clotting is thromboelastography. That's why if you remember that patient who we had down there, whose INR was elevated but his take was normal. The patient's INR was 3 point something. INR was 3 point something or 4 point something. Right? The patient's INR. Where is that patient?
What?
So INR was 3 and 4. But when you did the tag, what is the tag? Normal. You understand the tag was normal. The whole blood clotting will know. Why is that so? Because you have anticoagulant mechanisms as well as procoagulant mechanisms. Both are coming down together. So protein C, proteinase is anticoagulant. Okay, and is procoagulant. So that is also coming down. This is also going down. So since both are going down together, the overall system is the same. Only there is no bleeding. You understand? In fact, if you give FFP to such patients, you will lose the INR, which is a very important marker to understand liver disease. It's the other way. Clear? You understand? Huh? We stop for now. Huh?